The second case here has to do with a more complicated problem, which is a special kind of application for this system. This is a patient who has a missing canine tooth. She has undergone 4 separate bone grafting procedures for the purpose of creating enough volume at this site to place a dental implant. So she has had 4 surgeries spanning 5 years, and this is the result. The result is that there is a substantial remaining defect at the canine site, and there is no improvement in the volume of bone that would be necessary to place the dental implant. In addition, there has been substantial loss of the soft tissue at that site. The bigger problem here is that during the process of reconstruction and then failure of the previous 4 grafts, there has been damage to both teeth adjacent this site. Particularly the lateral incisor has lost bone clear to the apex, and the tooth has gross mobility. The tooth has been stabilized with an orthodontic appliance, and the patient then is being considered for subsequent reconstruction. This is a composite defect because the patient is missing multiple tissues, and each of these problems have to be addressed. The most obvious defect is that the volume of bone at that site is missing, so there's no way to place a dental implant. The second problem is that the canine tooth itself is missing, and that successful treatment must involve recreating or redeveloping a continuous dental arch. So we have to replace the tooth somehow. The third problem is that there is substantial loss of soft tissue, so that the grafting procedures that had been considered before were challenged by the limitation of the ability to close the wound over a augmentation type graft. A significant challenge, however, is the periodontal damage to the lateral incisor tooth. There is no obvious bone on the distal aspect of this tooth or even the labial aspect. There is a limited amount of damage to the mesial aspect of the premolar itself. Now, in order to create a stable reconstruction, all 4 of these defects have to be corrected. A simple bone graft will not likely reverse the periodontal damage on these 2 teeth, especially the lateral incisor tooth. So one choice would be to extract the lateral incisor and then attempt to bone graft over the larger gap. However, you are still missing too much soft tissue to be able to augment the ridge very easily. So in this situation, we want to consider a logical approach to treatment planning these kinds of problems here. So the first lesson is to examine the defect from the standpoint of not what the anatomical loss or defect is, but what are the intact aspects of the regulatory and structural system. So this is a different way to look at treatment planning defects of this nature, because the natural tendency is to focus on the loss of tissue, what we are missing, and that is what was done on the prior 4 treatments. The focus of the surgeons was to fill the gap, fill the deficit with some type of material in anticipation of then placing a dental implant. That approach failed. So this approach is different. This approach examines first what are the regulatory systems adjacent, surrounding the defect, that are maintaining the current morphology, because those factors are the factors that will control healing. So in this situation, we have to understand the limitations of conventional treatment. Now, The conventional treatment was to place a bone graft in this site. So the logical protocol in this system is to examine sequentially whether or not this reconstruction proposal meets the criterion for a valid bone-forming construct, according to the Harvold principle. Now, in this situation, surgeons had placed bone grafts at the site to provide an adequate number, or theoretically add an adequate volume or population of living cells. That is possible when you are using some type of viable graft, an autogenous graft. However, this plan will not meet the criterion for a bone-forming construct because, number one, it cannot create a volume which the center is stabilized. The defect is too big for the cells in the center to be in an environment that is stable enough to undergo morphogenesis and organization. The second aspect of this treatment plan that is deficient is that of neuromuscular regulation. Now, these cells, if delivered to the site, must have instruction to undergo morphogenesis and organization to achieve a viable and structural architecture to replace this bone. The only sites that are available to deliver signaling in this region are the periodontal ligaments of the adjacent teeth, which are too far from the center to be able to deliver this kind of information. The third defect in this treatment plan was that of an ability to isolate the chamber of regeneration from pathosis. Now, what I mean by that is that because the soft tissue is so deficient, even if you can manage to close over the graft with soft tissue, the tension on the flaps is such that integrity of the suture line cannot be guaranteed, and most often these sites become infected, and that will not be a condition that will grow living bone. So as an alternative plan, now this is a plan that we're trying to design before we propose any actual treatment on the patient, we will propose an osteotomy be done. In this situation, the segmental osteotomy is performed and then the segment protracted to close the gap and create a regeneration chamber at the site of the original defect and in a secondary regeneration chamber in the posterior maxilla, which we'll call a pterygoid regeneration chamber. In this discussion, we'll primarily talk about the anterior chamber. Now, from a surgical standpoint, we see here when we open this that the defect is wider than the normal volume that a canine root would occupy. But the challenge in this situation is the damage to the lateral incisor root, the periodontal structure on the distal aspect and the labial aspect. You can see also that there is substantial damage that's been sustained on the mesial surface of the premolar. So the osteotomy is performed through this limited access and the segment protracted, closing the space so that there is no gap in the dental arch, and then the segment is stabilized with a titanium bone plate and with the orthodontic appliance. You can see that the bone plate has been bent with a step which deflects the fragment laterally. The purpose of this is to position the Sharpie's fiber system that is embedded in the bone at the osteotomy site labially to allow direction of the fibers to have access to the labial surface of the lateral incisor. So even though we are looking at pieces of bone, and that is all we can see as surgeons, we have to understand that embedded in this bone is the Sharpie's fiber regulatory system that will direct healing in this region over a period of days and months. So Although we cannot visualize this directly, we need to know that there is a fiber regulatory system embedded in the living bone that will be the critical aspect of the healing regulatory process. Now, diagrammatically, we can see that as we protract this segment forward, the natural process will initiate a resorptive process of the bone that has been exposed. So this system will demineralize the bone that covers the mesial surface of the premolar. We have already explained that the embedded Sharpie system is immune to demineralization because it's not mineralized to begin with. The Sharpie system, consisting of collagen 1 and collagen 3, combine to create a system that is stable in the process of normal mineralization. Now, as the segment on the mesial surface of the premolar demineralizes, the Sharpie's fibers then become exposed into the chamber. In this situation, I am going to increase the population of cells in that site using a bone morphogenetic protein device. This is recombinant human bone morphogenetic protein 2. This material has the ability to chemotactically attract cells into the site to increase the cellular population. Because this BMP protein carried on a collagen sponge, there is no particulate matter that is being introduced. So there is no need to subtract mineralized material, so this is a purely anabolic process. There is no catabolic process that would initiate possible damage to the other tissue, including to the root of the lateral incisor tooth. So in this situation, we are proposing a design to create a chamber for regeneration that meets the 4 criterion for a bone-forming construct. The first criterion is the source of cells, which we will provide with BMP2 and some local cells. Because the chamber has been protracted into this narrow defect, the environment is stabilized by the roots and the bone. Neuromuscular input is then supplied by the periodontal ligaments and the Sharpie's fibers from them that extend into the chamber. Now, when this segment is protracted forward, it carries also the soft tissue. The soft tissue is transported forward with the segment, which allows for a non-tension closure of the chamber, over the chamber, with soft tissue. So there is an advantage in limiting the potential for infection, and so there is an absence of pathosis. So this chamber should have a high probability of healing. Now, before surgery, we can see this defect on the radiograph. After 14 months, we can see that the dental arch has been reconstituted by the transport of the premolars and molars forward. Examination of the reconstruction site itself shows there is mineralized material there which is filling the site, which is a good sign. However, it does not verify total regeneration. In order to have regeneration of this defect, we have to show that the periodontal ligament structure, including the periodontal ligaments and lamina dura, has been regenerated on the distal aspect of the damaged lateral incisor tooth. In order to have a lateral incisor that is viable long term, we have to be able to regenerate the periodontal system. So we watched this over many months. So one of the aspects of this is that the regeneration does not occur immediately. After 14 months, we can see bone has formed in that region, but there is no clear lamina dura. After 40 months of follow-up, we can see that the lamina dura has now reformed over the lateral incisor tooth, and also that the bone that is filling the gap shows a normal structural architecture with normal trabeculae. The presence of the lamina dura over the originally damaged lateral incisor tooth implies that a Sharpie system has been reconstituted in that space, because the lamina dura itself is a structure that is regulated by a penetrating Sharpie system. The Sharpie system that travels from the root surface across the ligament space through the lamina dura and into the alveolar bone is a system that has specific regulatory capability to create and maintain these structures. As a result of this reconstructive procedure, the dental arch has been reconstituted, the periodontal apparatus of the lateral incisor tooth has been regenerated, and it is stable and in a healthy state. The gingiva, as you can see, has been fully regenerated by this single process. This is the result of the single protraction process that I described. There has been no additional periodontal plastic surgery done to achieve this result. And this is the patient with her regenerated dental arch and smile afterwards.